Another important pre-lunch, pre-NIC data presentation symposium, newer insights into PCI optimization learned from masters. May I request Dr. Roni Matthew, Dr. Ziad Ali, Dr. Raj Dave, Dr. Ajit is not there, I think, Dr. Brian Pinto, Dr. F. Susili, Dr. Rajiv Pase, Dr. Selvam Mani, Dr. Sangat Velu, Dr. Santosh Sinha, and Dr. Rishi Gupta. Please come over. After this, we have, again, NIC data presentation session. So I request all the speakers to please speak to the time. And then we have interesting talks by international guest speakers. All those who are standing in the back, please come and occupy the chairs in the front, please. Over to you, Dr. Raj Dave, sir. Sit.
Okay, let's get started. Yeah. Welcome to this pre-lunch symposium, newer insights into PCI optimization learned from the masters. I'd like to start by thanking Abbott for sponsoring this session. I think it'll be an enlightening session. We're going to have experts in the field talking to you about some of the technologies that we are using on a day-to-day basis and finding out exactly how they can help to optimize our procedures and patient outcomes. We're going to start with Dr. Raj Dave, who's visiting us from the US, FFR for all my patients, standardization and application in complex PCI. Thank you, Raj.
Thank you very much. It's a privilege and honor to be here. Thank you very much, Dr. Srinivas and Dr. Kasturi, for their very kind invitation. And today my topic is FFR for all my patients. So in early 2000s, when FFR became more popular in US, the #1 concern as an interventionalist that I had was that now FFR is going to reduce my PCI volume. But as you'll see through this presentation, and which has come true into my own clinical practice, that our volume has actually not gone down at all by the use of the FFR. So many of you who has concern that FFR is going to reduce your PCI volume, that's not going to be the case. Now, why is that? FFR better defines, identifies the problem much better. So it's remarkable to see the discordance between what your angiography determines to be a significant stenosis and whether FFR classifies that lesion as physiologically significant. So if you look at the very left of this graph, you have moderate disease that's 50 to 70%, but you can see almost 35 to 40% of these patients have physiologically significant stenosis. So a lesion that you see today in your lab in India that you think is 50, 60% and you don't think that you need a PCI procedure, with the FFR, you are actually going to end up stenting those patients and your volume is not going to go down. And that's been the practice in our lab as well. FFR gives you more complete picture. So let's look at this artery that has angiographically 75% stenosis and it supplies a small amount of myocardium. Think about an example where you have an LAD that has 60% long stenosis in the mid-segment and you have a small circumflex coronary artery which has 75% stenosis. So this artery looks like a circumflex which supplies a small amount of myocardium by angiogram. And the same degree of stenosis in an LAD that supplies a large amount of myocardium, and both FFR value is going to be significantly different. So FFR not only takes into account the degree of stenosis, also the length of the stenosis and amount of subtended myocardium, and gives you a much better picture in identifying the correct problem that you should be treating. It better defines the extent of the problem. Here's the data from the FAME trial where angiographically you may have classified the patient as 3-vessel disease, but when you add FFR information to this patient, only 15 to 20% of these patients had true physiologically significant 3-vessel disease. Now we're going to talk about that a little bit more as we go forward. It better selects the stenosis that may benefit from revascularization. Think about bypass surgery. Today in America, our cardiac surgeons, when I tell them to do a bypass surgery on a patient with 3-vessel coronary artery disease, his first question is, what vessels you want me to graft? He's asking for physiological information on these vessels. So in this particular study, and there is quite a few of these, you can see that when the FFR is more than 0.8 and a bypass graft is put into a vessel like that, the graft patency is significantly reduced. There is a lot more grafts that get occluded when they are put into a vessel that does not have physiologically significant stenosis. So the impact on the bypass graft patency. So FAME trial, as you all know, has left the legacy of a treatment with FFR-guided revascularization in multivessel PCI versus angiographic guidance, and angiographic guidance was nearly not as good as FFR-guided revascularization. I won't spend a lot of time on this as you are very familiar with this data. There is very few trials in US that has really made the news. Courage is one of those trials, really created a lot of buzz. There was a New York Times article, there's multiple newspapers. Everyone said PCI procedure is bad, medical therapy is good enough, and my referring doctors now getting a patient with angina in their office are putting patients on just medical therapy and said there is no need to send this patient to a cardiologist because of this. Optimal medical therapy versus angiographic-guided PCI procedure. I'll bet there's quite a few limitations of the COURAGE trial, showed no significant difference in the overall hard outcomes at 5 years in COURAGE trial. Now, let's think about the FAME, where we showed that FFR-guided revascularization did significantly better with angiographic guidance. Now let's take the medical therapy arm of the COURAGE trial and superimpose it on the outcome of the FAME trial. And you can now see that when you add a physiological information to your PCI procedure, you are beginning to now differentiate your therapy from just optimal medical treatment. The interventional community's response to COURAGE was the FAME True, which compared optimal medical therapy versus FFR-guided revascularization and optimal medical therapy. And you can see even very early on, within the first 7 days, you start showing a significant difference in the outcome between these two patients, mainly driven in the optimal medical therapy arm by return of these patients for urgent revascularization. But they just didn't come in with the chest pain. A lot of these patients had significant EKG changes and myocardial ischemia and infarctions, and that's why they returned. So there is clearly a difference between these treatments. Now let's think about how FFR may guide the choice of multivessel PCI versus CABG therapy. Here's an example of a case. This patient has a totally occluded right coronary, has diffuse disease in the LAD, and a tight stenosis in the circ. Now, you all know from the syntax 1 that if the syntax score is high, we should be referring these patients to cardiac surgery. So we calculated the syntax score in this patient. The syntax score in this patient is 32. We know from the syntax that this is a good case for CABG. Well, is angiography enough? I just showed you a second ago that angiography and FFR has a huge discordance, and when we actually use the physiology information, we define the disease much better and identify the right lesion to treat. So we should be adding physiological information. When we look at the appropriateness use criteria, a patient with a syntax score of 32, the PCI indication is class 3. Now, functional syntax is the new way of calculating the syntax score. We should not only look at the anatomy, but we should also add the physiological information to the evaluation of coronary artery disease in these patients. Here is a reclassification of syntax score by adding physiological information. So on the left, you see patients with a low syntax score, high syntax score, and a moderate syntax score. And when you add physiological information, you saw a large number of patients moved from a moderate to severe syntax score to a low syntax score. So we reclassified a patient with a severe 3-vessel disease to now a 2-vessel or a 1-vessel disease. Now, when we measured the FFR of this patient's LAD was 0.84. And we recalculated the syntax score by adding this FFR information. In the same patient that I showed you, now the functional syntax score of this patient is 18. When we add the functional syntax score to the appropriateness use criteria table, now your PCI indication is class 1. This patient got 2 stents in the circumflex coronary artery, went home, and remains asymptomatic. Syntax 2 further defines the problem and guides our treatment strategy by using a full PCI optimization concept, where we're going to identify the patient with FFR information, that who should be treated, and then optimize the stent result by using imaging technique. So in Syntax 2, you had 1,100 plus patients, and you can see at the outset of the trial, 31% of patients had deferral of the PCI based on the results of the FFR. When you look at the number of patients in the Syntax 1 who underwent 3-vessel PCI treatment versus number of patients who underwent 3-vessel PCI treatment in the Syntax 2, when physiology was added to the equation, was significantly less. We know that the less number of stents we put in, the less number of vessels we treat, less complications, improves the outcome. 85% of patients in the Syntax 2 trial had intravascular ultrasound examination for optimization of the stent treatment. Now, does this matter? It only matters if we can show improvement in the outcome. So let's look at the outcome. So the blue are the patients who had optimized PCI in the Syntax 2, and the red are the patients in the Syntax 1 who had angiographic guided PCI procedure. And you can see there is a remarkable, statistically significant improvement in the outcome when PCI optimization was done. Now let's superimpose the CABG data from the Syntax 1 and compare that to an optimized PCI treatment of the Syntax 2. And you can see that the Syntax 2 optimized PCI wins even against CABG. At least it's not inferior to a coronary artery bypass grafting in these patients. So the functional syntax score better identifies patients with low to intermediate risk in whom PCI could be considered. Now let's think about multivessel disease in the setting of acute coronary syndrome, because many of the patients that come with acute coronary syndrome also has disease in the non-infarct-related artery, and we need to determine what should we do. So here is data from PriMulti on your right lower box, which looked at complete versus incomplete revascularization. On the left side, on the upper hand, is the data from FAME looking at patients with unstable angina and stable angina, and you can see that the FFR-guided revascularization was better even in unstable patients, and complete revascularization was better than incomplete revascularization. Compare Acute, which is presented last year, specifically looked at an FFR-guided complete revascularization in the non-infarct-related artery that led to a better outcome of these patients than just plain old angiographic-guided revascularization in these patients, shown here. A last concept before I conclude is, should you measure the FFR again after your PCI procedure? And there are many reasons why FFR could be low, and in the interest of time, I'm not going to go into a deep discussion of why it could be. However, a post-PCI FFR also is a very important measure that you should consider doing, because the patients, those who have high post-PCI FFR, you can see in the outcome difference, has a much better outcome than the patient who has continued to remain low FFR. So what could you do about that? If you do put a stent in somebody's LAD and you repeat the FFR and FFR is still 0.79, should you do something? So the clinical answer is yes. You might want to consider post-dilating the stent. You may have to add a second stent. Certainly, doing an OCT type examination on those patients will add a remarkably valuable information because a lot of these patients might have edge dissections that can also be responsible for low FFR. You may have underexpansion of the stent, you may have malapposition of the stent that should be corrected. It has been shown that an additional intervention in 30% of patients will increase FFR value as shown in this study in a post-PCI situation. FAME-3 trial is ongoing, which is going to specifically look at FFR-guided multivessel revascularization versus CABG. The results of this will be available in future and will shed further light to the concept of PCI optimization in patients with complex disease. So in conclusion, FFR is better at characterizing the nature and extent of the problem in patients with multivessel disease. It better defines when appropriate to revascularize and when not to revascularize, and is better at risk stratification, better identifying those that might benefit from multivessel PCI versus CABG. Thank you very much.
Thank you very much. So, Raj, I'll just start with maybe one question, which is obviously a hot topic, and that is, when do you use a resting index and when do you use a hyperemic agent? So specifically in situations where it might be difficult to obtain adenosine or difficult to obtain a hyperemic agent, either for cost or for procurement reasons, which of the patients can you rely on PDPA or other non-hyperemic pressure ratios, and when do you use that in your practice?
I'm having a really difficult time hearing here on the stage, but if I get the question right, when I use hyperemia versus IFR, that's question number one. So in our lab, we believe that maximum hyperemia is critical in accurately identifying the FFR. When you do maximum hyperemia, you increase the accuracy of the FFR in 90 percentile. With IFR, clearly from DEFINE and Sweetheart has shown that it is non-inferior. However, at least 30% of patients, those who we do IFR, we actually end up giving adenosine anyway, to define exactly what the value is. So it's very little work to then give all patients adenosine infusion. So in our lab, every patient gets an IV adenosine, 140 micrograms per kilogram per minute for FFR measurement.
Thank you. I think in the interest of time, we'll move on. If there's any pressing questions from the audience, please keep them, and then we'll discuss them at the end of this session. Right, we're going to move forward.
Can I have my slides?
Yeah, I can let that go.
Oh, that's not my slides.
Can you help him to change the slides? He's not able to.
Oh,
do
yeah.
that.
Okay, thank you very much. So my role was to discuss the role of OCT and clinical evidence, but I think in the presence of Ziad Ali, I don't really need to speak about evidence because he will be covering that with the next talk, and this will be a very practical talk on the use of OCT. First, maybe if we recall why does actually PCI fail, and there are clearly the identified factors which have been known for 20 years. Castrati described this here. So it's diabetes, it's chronic occlusions, it's in-stent restenosis, it's long lesions, and it's small diameter. And this hasn't really changed in the era of drug-eluting stents. And I think what we really need to be speaking about is stent underexpansion. I think stent underexpansion is the number one factor, or one of the number one factors why we have in-stent restenosis, especially in patients without diabetes. And stent underexpansion is very closely related to presence of calcium, because we know the presence of calcium will usually generate bad outcomes for our patients who are getting PCI. And of course, we know that if we treat calcified lesions, we sometimes might end up with something like this, which we don't want, and we need to understand how to avoid things like that, but still be able to expand our stents very well. And it's also true that coronary angiography is a great tool, but it has some limitations. For example, if you have a patient with in-stent restenosis, as shown in this case, on the left side you will have a patient who have massive neointimal hyperplasia. This is not something you can cover with another stent. If it's a drug-eluting stent, this is usually the patient I consider sending for surgery, because in this patient I don't think I can do a better job with another stent. However, on the right side, you have a patient who had in-stent restenosis and he was treated with another stent, comes now back, and you can see the second stent is massively underexpanded. So if you have an underexpanded stent, then of course you can first correct the mechanical factor and then hope that the next stent or drug-eluting balloon will cover it. Then if we have increasingly young patients, but these young patients have calcified vessels, as I will show you in this case. And very often these calcifications are not clearly seen on cornea angiogram. You can imagine that they might be there, but you cannot clearly see them, as in this case. However, if you do OCT, and I'll move quickly to the lesions to just save some time, in this patient, you can see that this patient has actually quite a bit of calcium around here, and you should take this into consideration. Now, this patient was part of a clinical trial where we randomized patients with all comers to absorb, and they were either pre-treated with a semi-compliant balloon or with a non-compliant balloon. Unfortunately, this patient with a calcified lesion, as you can see here, was randomized to the semi-compliant group, and we did the semi-compliant balloon dilatation at 12 atmospheres with a 3.0 balloon. And as you can see, semi-compliant balloons very often tear apart the part which you don't really want to injure, but they don't tackle calcium because they're compliant. And in this patient, we implanted a scaffold, and as you can see, even angiographically, you can see the underexpansion of the scaffold visible. And no wonder such scaffold would then thrombose eventually. In this patient, we were able to correct the underexpansion, which was evident with a high-pressure non-compliant balloon, but still the final result was okay, but it was not great on OCT. You could still see some underexpansion, and the diameter we reached in this 3.5 vessel was luminal not more than 3.0. Now, is this important? Is this really important, how you predilate the vessel and why you should be understanding the lesion? Yes, it is. In this trial, which I just showed you, which we are now submitting, you can see that if you predilate the vessel with a standard versus a non-compliant balloon, stent expansion index is slightly better with a non-compliant balloon after stenting, but it's not significantly different. However, if you post-dilate these patients and with a non-compliant balloon, both groups the same, you will see that if you have pre-dilated properly, the stent expansion index will jump up in the group with non-compliant balloons. However, it will only slightly increase with a semi-compliant balloon group, even if you use the same balloon at the same pressure. This means that if you don't tackle the vessel at first, and if we don't do a good lesion preparation, our stents will end up being underexpanded. Now, is this the only indication for OCT in your daily life? Of course not. This was the mother of the GP, very good friend of mine. I had to treat his mother, and she has this huge aneurysm. Now, how can I have a good result here with a stent and have a good long-term outcome? I put a stent in, and as you can see here, the stent was, of course, in the lesion, massively underexpanded and malopposed. So I then took a semi-compliant balloon and was able to expand this stent quite nicely and achieved a very good apposition in most parts of the stent, and this was then the final result. And I have a very good feeling that this patient will have a good outcome. As you can see in the cranial view, the diagonal was a bit pinched. I left the diagonal as it was, and I achieved with a 3.0 stent, I was able to expand it as good as I could, and it ended up being a good result. So without OCT, this would have been very difficult to know how far now I am away and what balloon should I use to really achieve a better result. Now, is stent undersizing a problem or malapposition a problem? Yes, of course it is. We knew that, or we found out with the scaffolds, because we identified in this very early series we had of thrombosis with scaffolds that stent underexpansion and undersizing were key factors of scaffold thrombosis. And I think with metal stents, it's probably the same, maybe not as pronounced as with absorb. Now, with the new Magmaris, you heard from Professor Castrati before, we have now new scaffolds on the market, and we should be careful, we should not be using these scaffolds without using OCT, and we should be using OCT especially if these patients come back to understand what's happening. This is a paper we just submitted. In A, you see early Magmaris dismantling. This is the biotronic scaffold. You can see that the scaffold, after 6 weeks, you see the strut swimming in the lumen. And this is a phenomenon called dismantling. And as you can see in B, this is after 13 months, you see fragments of this scaffold swimming in the lumen. And the series we submitted now, we have a thrombosis rate in 105 patients of 6%. So this is clearly relevant, and I think OCT plays an important role, as it played in Absorb, to understand what's happening with this patient. And you have been also hearing about inhomogeneous resorption, and this is a clear example. After 14 months, you can see on the left side, very nice result after implantation of 2 Magmaris scaffolds. After 4 months, you have instant restenosis, and you can see on C, you see collapse, and on F, you see also collapse and scaffold fractures. On E, you see some negative remodeling, and on D, you see positive remodeling. So this is happening in the same patient, and I think without OCT, we cannot be understanding this. Now, should OCT tell us something about plaque? Where do I use it? I use it in patients where I don't understand what's happening to this patient. He arrives, we see some troponin, but angiographically does not convince me. And I think for these patients, it's good to have an idea what is going on. This was a patient, young patient, 40 years old, with an inferior MI, which we treated previously, and then he came back after 6 months and had this lesion angiographically. It was not convincing. You could be using FFR in this patient, but I really wanted to understand in this patient who had previous MI and who was also resuscitated, is this really another plaque rupture? So I did OCT, and you can see this is textbook-like. You see the plaque rupture acute happening, and of course I felt that I should be covering this plaque with a stent to prevent the next infarction, which could kill the patient. And also in all the patients where angiographically the lesion is not convincing, if you look on OCT, you will see plaque rupture, you will see thrombus, and you will know you should be covering this, and you should tackle this patient with an aggressive secondary prophylaxis therapy. And also in patients, this is the last example, in patient where you have a stent previously, you can see plaque rupture in neoatherosclerosis. So this is really happening after 4 years in this patient. And calcium, as I started with calcium, yes, it is a problem, and very often not only the expansion of the stent is a problem in calcified lesions, but also the apposition of the stent. So what I have come to believe is that you should try to expand your stent with a non-compliant balloon, as I showed you, pre-dilatation and post-dilatation, but you should try to oppose your stent with a semi-compliant balloon, because very often in these non-symmetrically distributed vessels, it is very difficult to achieve good apposition of the stent with a stiff balloon. And the final example, I showed you this case before, a lot of calcium and then tackled with OPN and 4 stents implanted to achieve a good result, but the left main looked a bit hazy, and in order to really be able to sleep that night quite quietly, we did OCT, and then on OCT the result was actually quite nice. So I basically then said, okay, let's finish this. So to summarize, for myself, there are 3 fundamental rules of PCI. One is we have to understand the difficult lesion, and as you heard by Dr. Dave, in intermediate lesions we should be performing FFR, but if the lesion looks difficult, we should be performing some kind of imaging, because these lesions are important. They might cost us more than we think in the future, and especially the patient. So I think, and then if we see calcium, then and if we see it's really circular calcium, thick calcium, then we should be tackling this before we put a stent in. The worst thing is to have an underexpanded stent, which then leads you to very aggressive post-dilatation with a big balloon, and then, of course, the risk of rupturing the vessel. And I think for this you can use rotablation, you can use any devices you have in your shelf. I have the OPN balloon, and with that I'm doing very well, but that's very important to really tackle this. And the third thing is, if you implant the stent in a difficult lesion, I think it's important to realize that expansion will lead to, that non-compliant balloon will lead to stent expansion, and very often when you use imaging, semi-compliant balloons will be needed to achieve a perfect stent expansion. So this patient is fine even when he stops clopidogrel in some time. Thank you very much for your attention.
Thank you very much, Dr. Kukuli. A very nice presentation. In the interest of time, we are going to move along because we are already a little late in the session, and I'd like to invite Dr. Ziad Ali now to talk about beyond iLumen 3, step-by-step stent sizing and optimization by OCT.
Thank you, Raj. So this is purposefully a very practical approach to step-by-step stent sizing and optimization by OCT with very minimal data behind it. Frozen. Okay, so I'm going to break down OCT for you into 7 very simple steps. There should be a pre-intervention assessment where you assess the plaque composition, identify your reference segments, and choose your stent size. During stent deployment, the goal is to deploy from normal to normal, and we're going to do that using angiographic co-registration. And following stent implantation, determine whether or not our stent is fully expanded, the critical nature of which was just described. Finally, complications and post-procedure assessments divided into identifying stent problems, which include malapposition and tissue protrusion, and identifying edge problems, which include edge dissection and reference segment disease. Let's start with assessing plaque composition. In order to be able to understand plaque composition using any intravascular imaging modality, I think it's very important to first understand the different layers of the artery wall. The innermost bright purple layer is the intima. Inside of the intima is a rubber band type structure called the internal elastic lamina, which is bounded by another lamina called the external elastic lamina, bounding the media, which is a very thick rope-like material which provides structural integrity to the heart. On the outside of the layers of the artery wall is the adventitia, which is a thick, hydrated mesh-type material which keeps the artery intact. Why is this relevant? It's relevant because OCT is the only modality which allows you to see each layer of the artery vessel wall with extreme resolution, similar to a pathologist slide. This is all of the OCT image interpretation you will need to know to start your practice as a practicing interventional cardiologist. In every situation, you should ask yourself, are you able to see the media or the external elastic lamina or the adventitia? In any of these situations, if you're able to see both of them, here you can see this mesh-type material on the outside of the artery, and you can see the media, which is this double black line. This is a fibrous plaque. In situations where there is a signal change in the lumen or wall, that is an abnormal artery. In that situation, if the signal changes in the wall and it's high attenuation, meaning that the light is absorbed within the lesion, this is lipid. However, when you have a signal that's low attenuation, meaning that the light hits a substance and then refracts, but you are still able to see behind it, this is calcium. And if you're ever interested to determine whether something is low attenuation or high attenuation, a simple strategy is to ask yourself, can I draw an outline around the signal change? If you're able to draw an outline around the signal change, this is calcification. Why is this important? Why can't we just use the angiogram? Well, the reason is that the angiogram is significantly limited. Here you can see what looks like a simple, straightforward type A lesion in the second obtuse marginal, but unpredictably an undilatable lesion. However, intravascular imaging identifies to us very clearly at this point there's a protruding calcific nodule that will require atherectomy because the implantation of a stent in this situation is likely to lead to underexpansion. We have recently described the first scoring system for calcification that allows you to determine whether or not you should perform more aggressive dilatation or, in fact, atherectomy for lesion preparation. This very simple scoring system, which includes understanding and determining whether calcium is present for half of the arc of the artery, has a maximum thickness of more than 0.5 millimeter, and is 5 millimeters long, can predict whether or not you are able to expand your stent. The beauty of this very simple methodology is that it's called the rule of fives. It's half the vessel of the arc of the artery, 0.5 millimeter of thickness, and 5 millimeters in length. And as you can see, if you have all of these criteria, you have a significant chance of stent underexpansion. How can this help you? You can see that in fact when you do have a lesion that has a calcium score of 4, such as this patient that has 5 millimeters in length, more than 0.5 millimeter in a thickness, and greater than 180 degrees in arc, lesion preparation should go ahead with atherectomy. Atherectomy works in a wire-biased manner, and here you can see that the atherectomy actually shaves down the calcium within the vessel wall to less than 0.5 millimeter thickness. Following this, high-pressure non-compliant balloon dilatation is able to fracture the calcium at its weakest point, ultimately leading to optimal stent expansion. This is a very simple strategy based on plaque morphology of how you can perform lesion preparation by OCT. If you see a largely fibrous plaque with high reflectivity, it's very safe to perform direct stenting. If you see a fibrofatty plaque where there's a large amount of signal attenuation within the wall, direct stenting or the use of a compliant balloon can be used for vessel preparation. In situations where you have a calcium score less than 2, compliant balloon or non-compliant balloon should be adequate, but when you have a calcium score of greater than or equal to 3, that means half the arc of the vessel wall, 0.5 millimeter in thickness, and 5 millimeters in length, a non-compliant balloon, specialty balloon, or atherectomy are recommended. Once you've determined your plaque morphology, the next step is to determine where you're going to land your stents, both proximally and distally. And the beauty of the OCT is that it has this very important feature called the automated measures, which is this cartoon-type structure. To put this in context for you, this cartoon structure is every measurement for every degree of the artery, like a CT scan, rather than taking a sagittal section of the artery, which is what is normally done either by IVUS or using angiography. In this situation, you use this just as you would for an angiogram. You identify segments of the artery where you believe you would want to land the edge of your stent, and then you review those sections and determine, is this a suitable place for me to land my stent edge? Here you can see the media all the way around the artery and the mesh or the adventitia all the way around the artery, and as a result, this is an excellent place to land your stent. However, when we place our marker distally, we identify a large area of fibrofatty plaque, and thus this is a suboptimal place to land our stent edge. In this situation, what should happen is you scroll the vessel to look for a segment of the artery that is more healthy, and just 4 millimeters away we identify a segment that's completely normal. As a result, stenting from normal to normal is the ideal situation and is completely guided by OCT. Does it really matter? You may say, well, I can use the angiogram. Well, here's an example. Here's a patient from our institution where the operator performed OCT but did not pay attention to the plaque at the distal reference segment. And you can see that there's a thin cap fibroatheroma at the distal reference segment, and this is the outcome of implanting a device into this thin cap fibroatheroma. And you'll see that, in fact, what this shows is a large intramural hematoma, the result of the implantation of the BVS into the thin cap fibroatheroma. Co-registration was not utilized. It led to a geographic miss, which led to an intramural hematoma. Why do we care about this? We care about this because perhaps in contemporary drug-eluting stent failure, edge problems are the single most prevalent of all of the causes of target vessel failure. Approximately half of all lesions in current generation DS are related to the edge, either proximally or distally. And of course, evidence suggests that's intricately related to both early thrombosis, restenosis, and MACE. How do you choose your stent diameter by OCT? Well, I think it's important to understand a little bit of the background, and that is that OCT and IVUS measurements are not the same. The OCT is extremely accurate and precise. If in a phantom model where we bought a plastic tube from a manufacturer and measured it using OCT, the OCT is almost perfect in its ability to perform measurement. However, IVUS oversizes the artery by about 10%. And if we take that information in vivo, we find exactly the same finding, that in fact OCT is extremely precise and IVUS oversizes. What does this mean to the practicing interventional cardiologist? Well, what it means is in the situation where the OCT is telling you that the mean diameter is 3 millimeters, the exact same measurement performed in the same measurement in IVUS will tell you it's 3.3 millimeters, leading to the choice of a larger stent by IVUS. How do you choose your stent size by OCT? You choose it according to the external elastic lamina. The reason we choose the media or EEL is because it leads to a significantly larger area despite having just a small increase in diameter. Large increase in diameter lead to huge increases in area. You may ask yourself, well, I can just use the lumen and upsize to the stent. Why do I have to use the media? This is work performed from our institution, Columbia University Medical Center and St. Francis Hospital, where you can see that the mean difference if you choose the lumen and upsize your stent versus the media or EEL and downsize your stent is 0.63 millimeters in diameter. This is a huge difference in terms of your stent area. But what does that mean in terms of interventional cardiology? Well, what it means is that if the optimal cutoff for a target vessel failure of less than 2.5% is 6.8 millimeters squared, your original 2.75 millimeter stent optimally expanded would get you a 5.9 millimeter squared area. However, instead choosing a 3.25 millimeter stent puts you on the flat part of the curve, reducing your target vessel failure to 2.5%. Why again do we use the external elastic lamina? Because every other study that compared another modality against OCT has won because the OCT undersizes compared to both angiography and to IVUS. Only Illumian 3, the randomized trial which forced the operators to use the external elastic lamina, was able to match IVUS in its ability to achieve a minimal stent area. What is the OCT stent sizing algorithm? Put simply, we perform a pre-PCI OCT, we measure the external elastic lamina or media at the proximal and distal reference segments if possible, and if the EEL is visible, we use the distal reference EEL rounded down to the nearest stent size to perform our procedure. This should be able to be performed in 85% of cases. Only in situations where you cannot see the external elastic lamina should the lumen be used, and the lumen is only necessary to be performed in 15% of cases. The OCT is extremely accurate and precise. So if the OCT tells you to take a 28 millimeter stent, you can choose a 28 millimeter stent. There is no need to use a larger or smaller stent to accommodate. One of the major advantages of OCT is, of course, its ability to perform co-registration. Angiographic co-registration is the ability, which is unique only to OCT, to look to the artery from both the inside out as well as the outside in. Here you can see I'm performing angiographic co-registration in real time, and as a result have the ability and opportunity to look at the artery in ultrastructural detail from inside the artery with exquisite detail. The standard deviation of the OCT co-registration is less than 1 millimeter. Why does this matter to you in practice? It matters because we mark exactly where the stent needs to be placed. Here you can see markers placed at both the proximal and distal reference segments, and as a result, the stent is placed with extreme precision. The standard deviation of stent implantation by angiographic co-registration is now within 1 millimeter, thus eliminating the concept of geographic miss. Once we've placed our stent, of course, we want the OCT to be able to help us to determine whether or not we've achieved expansion easily, reliably, and predictably. And this is the major advantage of OCT over IVUS. Here you can see OCT provides all of the measurements automatically, whereas IVUS requires manual interpretation, introducing the problem of human error. How exactly do we determine expansion? When the first thing to do is turn on this extremely useful feature of OCT called the rendered stent, and then divide the stent in half, simply placing your markers at the proximal and mid segment of the stent. Once you've done that, the OCT automatically identifies the minimal lumen area within your stented segment and highlights for you the area stenosis that's residual within this segment. Thus, you can see here the stent is 95.6% expanded. No further treatment is necessary. The same thing is performed in the distal half of the stent. The markers are moved to the middle and distal end of the stent. The minimal stent area is automatically identified, and as a result, you can see the stent is fully expanded. Why do we divide the stent in half? Of course, as we place longer and longer stents, 38 or 48 millimeter stents, you can see that the stent needs to divide because of tapering of the vessel with each branch. If you're not interested in dividing the stent in half, of course you can perform an entire stent expansion with 2 simple steps, placing the markers both distally and proximally and looking at your residual stenosis. This is the OCT stent optimization algorithm placed for you extremely simply. Following angiographic co-registration guided stent implantation, you take an angiogram to see whether you have any angiographic residual diameter stenosis. If you have an angiographic residual stenosis, you perform an angiographic guided optimization using the balloon sizes which are already predetermined from your pre-PCI OCT, thus saving time and contrast. As a result, your pre-PCI OCT chooses your post-dilation balloons even before you're ready for post-dilation. Only following the point at which you believe you have completely optimized your stent strategy and completely optimized your stenting at the point which you're ready to pull out your wires should you perform your post-PCI OCT. Then you determine whether your target minimal stent area is achieved, and you use your new balloons for post-dilation based on your post-PCI OCT. The last section that we do before completing the procedure is we confirm that there's no major edge dissections and that there's not a minimal lumen area less than 4.5 millimeters squared in the reference segment. How do we identify stent problems? Of course, OCT has extreme resolution, able to see stent struts that are not able to be performed on IVUS. Apposition indication is automatic on OCT. You can see these red bars that are painted into the stent automatically identify segments of the artery that are 0.2 millimeters from the stent edge. While there is not clinical evidence to suggest that acute malapposition improves clinical outcome, this has to be taken in the common sense. Here you can see an extremely underdeployed stent in the distal right coronary artery with a predictable consequence of subacute stent thrombosis. Tissue protrusion is something else that you can identify with OCT with extreme resolution. This should be treated when it's occupying a significant amount of flow area, 10% of your effective lumen area. Why does this matter? It matters because it's an independent predictor of stent failure, target lesion revascularization, and device-oriented composite endpoints. And again, you can see that major adverse cardiovascular events are significantly common in this patient population. Determining edge problems, we make determination of what lesions should be treated by OCT extremely simply. If you have an arc of greater than 60 degrees, if your dissection is longer than 3 millimeters, if it's flow limiting, or if there's an inadequate MLA defined as an MLA of less than 4.5, that edge dissection should be treated. Why is OCT superior? It's superior simply because of its resolution. Here you can see the same patient imaged with IVUS and OCT. The dissection is very difficult to determine on IVUS, but very simple to determine on OCT. And this played out in randomized clinical trials, which showed that dissection detection is significantly superior using OCT, and as a result, you leave the least number of untreated edge dissections using OCT compared to IVUS. Why should you even care about these dissections? You care about them because you can see that major adverse cardiovascular events, target vessel failure, and MI are significantly more common in the dissection-treated group. Finally, you need to ensure that the reference segments, both the inflow and the outflow, are normal. Here you can see that the stent is perfectly expanded. There's no residual lesion. However, proximally there is a major geographic miss, and this is an independent predictor of target vessel failure. This registry, called the CLEO-PCI registry, clearly showed us that when you have an in-stent MLA of less than 4.5 or a distal or proximal reference narrowing less than 4.5, that the hazard ratio is significantly increased. So in summary, I leave you that you can very simply perform OCT in an evidence-based manner in a protocolized strategy quickly and effectively to optimize PCI strategy and outcomes. Thank you very much.
Thank you, Dr. Ali. Now I know Dr. Srinivas is anxious to proceed with the NIC data presentation. So we're going to continue to move on. The one last thing I will say while the next set of panel members come up is that the prices of the best-in-class DES such as Zions has gone down so much in India that the multi-vessel PCI procedures are going to increase, and PCI optimization concept brings real value for your patients. So great presentations. Thank you very much, and I'll turn it over to Dr. Srinivas Kumar.
Thank you, Dr. Dave. And now we go on to the most important, most awaited session of NIC, which only this conference can give to all of you. All of you, I know, are eager to know the data, what is happening across the country. This is the most important session of this conference. And as a protocol, we request all our senior colleagues, past presidents, president-elects, and the secretary to chair this session. And also invite one or two international faculty to give us some guidance to how to proceed further. So I request Dr. Sharat Chandra, our President, CSI, to come onto the dais. Dr. Keval C. Goswami, our President-elect, to come onto the dais. Dr. M.S. Hiramath, our past President, come onto the dais. Dr. Amal Kumar Banerjee, Dr. Shantanu Guha, our past Presidents, Dr. N.N. Khanna, immediate past NIC Chair, Dr. Saumitra Kumar, our Secretary, CSI. But unfortunately, some of this audio-visual system in HICC looks like people who are sitting in front could enjoy it best. There is little less discomfort to the ears to understand it right, but now, as a protocol, we request all of them to come and... Is Dr. Ajay Kirtane here? Yeah. The idea to have you also is to tell your perspectives and guide us to how to proceed further in this area. Lord Sharath, can I start? Or?
Yeah. Thank you, Dr. Srinivas Kumar. Traditionally, this is a very important session. It's a highlight of NIC meeting. And we have with us so many of the CSI executive members, past presidents, and by tradition, the NIC chairman presents this data, which has been collected over the last few months for the year 2017. And now I request Dr. Srinivas Kumar to go ahead and make the presentation.
I request all those who are standing behind, please occupy your chairs, please. And good afternoon, all of you, and all the respected senior faculty sitting on the dais, and my dear friends who are off the dais. It's indeed an honor, pleasure.
Srinivas, what I would like to say is you will be talking for 20 minutes.
Sorry?
You'll be talking for 20 minutes.
Yeah, whatever you say. 20 minutes we'll have presentation,
Okay.
10 minutes discussion.
Okay, no, that's fine. So, you know, after the presentation is over, I'll be asking for the opinion starting from the left. Each one give a very brief remark on this. Okay, let's go ahead.
And Dr. Sridhar also wanted to briefly give some message for a minute or two in the end. Okay, again, coming back, it's indeed pleasure and honor for me to stand as NIC chairman to get to you this important information regarding what is happening across the country in the interventional cardiology field. First, salutes to the contributions of this great man, Andreas Grundzig, who made this procedures possible, and now that's how it could save long lives. And other person who made this very further is a person who is standing on the right, Geoffrey Harzer. Many other tributes to a lot of stalwarts across our country, in our India, and tribute to Professor Sujoy B. Roy, founder of invasive cardiology, then many other senior colleagues in the country who helped us to grow in interventional cardiology. Coming back to personal level, my alma mater institutes, Usmania Medical College, Usmania Hospital, where I graduated, MBBS MD, and then I got a lot of inspiration from teachers like Dr. Somaraju and Krishnamraju to become the cardiology, take up this profession. And Sanjay Gandhi Postgraduate Institute of Medical Sciences is, I would say, cardiology alma mater, where I got tuned and trained further in these procedures. I'm extremely thankful to all my teachers, specifically Professor Nakul Sinha and Professor Dr. Goyal were my training teachers, though I joined under Dr. Savitri Srivatso, but they were instrumental in me developing further into cardiology. And after that, thanks to our present hospitals, and proud to present our group of cardiology colleagues, a wonderful cardiology team. We run this cardiology, we're about a team of 27 cardiologists and 3 cardiac surgeons. We want to give heart team approach and render services in multiple hospitals as mentioned there. How it is very apt and important is this could become a role model for all of you who could collect the data collectively, and all of us together can have so much volumes of data which is coming up. I'm thankful to all my colleagues in spite of very patient pressures and working on this. They were all cooperated day and night, not mentioning individuals, but all of them play a significant role. My special mention has to be done to Dr. Sudhir, a new colleague who joined from UK. He was with the British Cardiac Intervention Society before, and a lot of inputs and how to analyze the data, we took it from him. Thank you, Sudhir, and then probably British Cardiac Intervention Society. Coming to data presentation of today, though it looks easy, but it's a long, challenging process to get to this data. So what I would do in coming 15-20 minutes is briefly tell you about how this data process has happened, what are the challenges in doing it, and the message is basically why are we all doing it is to analyze and to see how best we can improve further in future. Then the most important thing which I thought, apart from the numbers and all that which we see, is a data subset analysis, which will go into details like left main subsets and CTO subset, things like that. Whatever information you could collect, probably you could expand further in future, and then probably we can bring out more meaningful research which will help our patient population in future. So in the end, I would briefly mention what are the future plans in the coming year to do it. Data collection, why are we so much bothered is, basically it is a factual depiction of current trend, which is helpful in understanding trends, disease pattern, and therapeutic treatment. If you understand what is going on, then we can plan our treatment modalities better. But if you see what are the challenges in data collection, we unfortunately do not have any dedicated system of neither cath lab registrations nor seriousness towards data collection. One thing which I would say which has benefited most is whichever people have submitted, the faculty will be selected from that only for this NIC conference. That gave a lot of impetus to people to send. But I don't want it that way. We should all feel that we are part of it, and we should wholeheartedly contribute what is positively correct data to this so that we can improve on. Then the challenges are, which are there, unwillingness to share the data, unwillingness to share the complications. I would say each of us would face some complication or other. We should be willing to share so that we can avoid such in future. And as of now, there is some criticism of this data that validity is not tested and all. For me, what my colleagues send is of top priority, and we have to believe it, and that's how the validity of it has to come. I would agree that probably we could have some methods in future to improve. How the data is collected, as you know, we took help of Mr. Saket of JVS in organizing this, and we kept on sending multiple reminders, messages, phone calls through this and to various centers. And I'm happy that at least numbers of contribution of said data is improving year by year. Some of the secondary sources of cath lab data which I thought I would verify is from governmental sources. and also from cath lab companies and industry colleagues, device companies, and some of these websites which have. So what I've surprisingly noted is the beauty of large data collection is this. So everything boils down to roughly around the same figures. It will even out, even if you're missing some out to 20-30% data. If you have large volumes of data, that's how it scores. If you see, compared to what we started before, where we used to have representation of only about 40%, it increased, and Kanna did a good job last year. It increased to 698. I'm happy to share that this year we could collect successfully data from 705 centers out of 1,000 plus centers which are there in our country. So it's a positive trend, but I wish it should go further to more than 90% to probably 100%. But the 705 centers, again, doesn't mean that the number should go up same, because unfortunately, changing scenarios, about 40 labs closed down in the country. So we do have that data information also. Data reporting and interpretation. Now this is how we need to see. Changing scenario is the estimated growth of stents, balloons, and nowadays with the policies coming up of no use and reuse, then probably the numbers would go up with the cath lab accessories as well as obviously with stents, decreasing pricing. So this we need to understand. Other contribution of the increase in the volume is basically more and more centers are equipped and more cardiologists are getting trained. Technical advancements happening through better quality of stents and products, and STEMI protocols are evolving. So India is on the rise, and that's how I feel patients are getting better treatment, and a reduction in stent price could also help patients indirectly, though there are challenges to hospitals and companies. More and more smaller type of cath labs are being designed by companies for Tier 2 cities, and the maximum development and expansion is happening in this field. Then some facts to recapitulate from the earlier years so that we could proceed to this year. We had something like 530 cath labs reporting 1,77,000 interventions in 2012. Last year it increased to about 3,70,000 procedures. Primary PCIs we started from 21,000. It increased further to about 56,000. And high volume centers which were doing more than 1,000 angioplasties were there, contributing more. Now there's slight change, and younger people contribute about 12.5% before. Now coming to see, I would like to acknowledge Aster Aadhar Hospital, Kolhapur, which was the first to respond. Day one, they sent the data, and the complete data. I express my thanks to them, and I congratulate, I wish Dr. Manjunath is here. Because of elections being held there, he's officially occupied there, that's why he couldn't be here. But any other faculty from Jayadeva is here? Dr. B.C. Srinivas was there, others were there. I congratulate them for being the leading center, the topmost center in the country for a number of procedures. Then single institute, they have done 9,270 PCIs. We should be also appreciating this center, not only for that, because they also, data sending is totally perfect and complete. All the parameters which are asked will be were sent in detail. That's the level of commitment we need. And if similar data can come from others, then that will give more and more authentic data. And some of the things which I would suggest in the end, how to improve further. We see this. Because we have kept a rule that faculty will be selected, only this is sent in this. I'm sorry, I don't know which hospital, I don't want to go into details. Number is only filled and sent. Nothing else is there in this form. I didn't consider such things in analysis. You see, on the other hand, the right-hand one is depicted right, though large volumes and everything is filled up correctly. That's what we considered in analyzing the data. So top 10 centers of PCI volume in the country. Jayadeva obviously is mentioned, way ahead, 9,270 PCIs. And next is GBP Pant Hospital, Delhi. I congratulate again Vijay Trehan, Dr. Sanjay Tyagi and others for this, and their numbers are about 7,096. Phenomenal volume of numbers compared to any other. Some of the countries would do such. That's a greatness of our country. But if all of us can put our efforts together and make further improvements in our collection of data, we could have very strong positives. The other thing which is also is, in spite of a lot of challenges we have in governmental setups, a lot of criticisms happen, but a lot of high volume centers are happening in government, apart from the corporates also, which do some, which are mentioned here. Then this is another newer addition which has increased up in the compared to last year, UN Mehta Institute of Cardiology, Ahmedabad, again, which is not there, significant increase in numbers. I didn't know what is this number, 9 hospital, only now we saw it. This is one center in Gujarat, again did a phenomenal work. So we congratulate these top 10 centers of PCI. Now we go on to state-wise performing centers, which reported reasonably complete data, I would say. At least 70% of the data is mentioned. Some things, only values are mentioned, we didn't take. Andhra Pradesh, we congratulate Lalita Super Specialty Hospital, Guntur, which is headed by Raghav Sharma. I didn't know that they were doing so much good work. Congratulate them. And not only to mention this, other important thing is that the leading center in the country for performing carotid interventions. They did 106 carotid interventions alone in that center in the periphery, quite appreciable. What we have to learn, I've gone into the nitty-gritty and saw how they could be able to do. His wife is also a neurologist. So that's how neurology and cardiology cooperation, I think it will do more good to patients. So multi-system specialty, helping each other would go a long way. I think many of the people who are sitting, that's the beauty of our country, be it east like Assam, Bihar, Chhattisgarh, New Delhi, North, South, and all the centers which are mentioned here are there. That's how we get a varied, valuable data which comes from our country. That is the strength of our country, and at the same time, we should utilize it properly. If you see Kerala, just to mention for sake of reasons of time, I'm not going to details of every of the state, but some of you are sitting here could watch it. Then coming to the rate of growth from 2016 to 2017, those centers of 705, the number I thought should have gone up further, but it is about 3,87,416 interventions. The rate of growth is 3.7%. Probably it would have gone up more unless we had number more, but about 40 centers got closed. So that's how I think numbers which are supposed to increase by about 10%, what we thought is about 3.7% growth. That's a coronary intervention growth. Then procedure volume-wise, center-wise bifurcation. Why it is important for us to understand this is there's a large number of Tier 2 cities coming up who do less than 200 PCIs and contribute about 5% as before. And more than 2,000 procedures are done in about 20 centers in the country. They contribute about 20% of the total volume. And then 1,000 to 2,000, about 25%. And most commonly, I would feel in the country, average centers do somewhere in between 500 to 1,000, which contributing about 28.3%. So if these high volume centers together can come up to a platform and create some 100% data registry, then the information goes up like anything. So if you analyze and see these numbers, these numbers are much, much more than British Cardiac Intervention Society, which I took it as a landmark for comparison. They have some like 3.1 procedures done, but about 15 research papers come out of that every year. If you see this is the same. More than 2,000 procedures, about 3.3% centers, about 20 centers which perform, but the amount of volume of work which comes from there is about 20%. But we should be, again, happy that even the Tier 2 cities are able to perform and deliver and save some patients. I have seen this in a lot of CDs which are sent for the presentations. Interesting work is being done in the periphery. Age groups, less than 40, as we know, is same, 12.2%, but nowadays we do more complicated cases, complex procedures, patients are surviving longer. That's what came out. More than 70 years is about 17%, 2% increase compared to last year. And gender data, this is not different from earlier things. It is about 70% male versus 30% females. Then so the source of funding, this is again an area of interest not only for us, not only for patients and also for companies. Government resources, funded insurance is about 43%, same like last year. And the private insurance, which is about reasonable packages, are about 17%, and still about 40% payments happen through patient's own pocket. So all the big players who are here, request who do not want to enter this, request is to take care of these patients too, not only for the paying patients. We as professionals also try to do treatment across in the same way. Coming to various indications of PCI, the primary PCI contributes about 13.74%, post-MI is about 16%, And unstable angina is about 25%, stable angina is about 20%. It's roughly the same patterns, and also heartening to note that cardiogenic shock patients are also being treated, and rescue PCI also contributed some significant amounts. Coming to the vessels treated, single vessel, as we know, it predominantly dominates, but multi-vessel disease also contributes about 20%. Left main, after the Excel data and Noble data, we are more confidently offering this therapy to these patients. Probably it has doubled. Compared to last year numbers. I will tell you briefly slightly more details of this which I collected. Graft angioplasties did not increase much. Coming to left main interventions, there could be some fallacies in this because it is both statistical jugglery which we did with following some BCI style, and then total number of left main PCIs done in the country is 9,600. Though it is only 2.5% of total interventions, number of patients is huge. That's how it's very important to understand. Often we talk about how many of image-guided procedures are done. In this data, it shows that 22% of left main PCIs are alone or done through image guidance. We wish it could further increase with more availability. That's how optimization of technique with OCTs being available, which is easily interpretable, probably these numbers could go up in future. Another interesting aspect which I have noticed is when acute MIs are identified, about 1.9% of them had some sort of involvement of left main in these patients. And bifurcation left mains contributed about 23% out of all, 2,200 plus were left main bifurcation interventions. Then coming to other types of bifurcation PCIs contributed about 4.5%. CTOs, again, though it is 3.6%, volumes-wise it's contributing roughly up to 14,000. Some are instant restenosis, minimal numbers of retrograde PCI. When I try to see a little more in detail about CTO PCIs, antegrade is more common as expected, 97%. Retrograde is just picking up about 3% of total PCIs. 391 procedures are reported. And then microcatheter usage is, I was a little surprised, about 66% of procedures, at least they have noted that is taking this help. Graft PCIs, PCI to venous grafts is more common, obviously, but 20% of them also reported Lima procedures. And distal protection devices were used in about 27% of all these interventions. Then POBA only, we feel it is less common, and some small vessels, I think it is being used, 2%. And GP2P receptor blocker usage, though we thought it should go down further, but probably in periphery where there's more thrombus load, still about 18% patients, it is still being used. Vivalodin did not pick up. Angioseals with less and more usage of radial, probably this is further around 2%. Other devices, procedures, rotablation, there's though a lot of training programs do happen, about 3,769 procedures with rotablation are reported. Intravascular ultrasound, 4,490. OCT somehow now we couldn't capture. Fractional fluorescers, again, about 5,000 plus procedures are reported in this. Coming to this interesting aspect of interventions in acute MI, we had about 53,416, slightly less than what we had in earlier years. It doesn't mean that numbers have come down, but basically some of them of taking up for pharmacoinvasive strategy also with the better lytic therapy, which would actually have come into the post-MI phase. So the collection of data regarding acute MI, though not directly part of NIC registry, but about 30 lakh MI patients are roughly estimated in our country, out of which 12 lakhs go for thrombolysis, and about 56,000 are receiving primary PCIs. And some of them could go rescue and other things. So what we have data is about 56,126 primary PCI procedures, and this contributes about 13.7% of total interventions. Thrombus aspiration, when we try to see there's a lot of controversy happening, how many patient procedures thrombus aspiration was used, what is reported is about 1/3 of patients it is being used. Maybe it is becoming less common now because of data coming up. And cardiogenic shock patients, about 9,000. We are doing so much, I felt happy with this, but probably because of low-cost incidence schemes, whenever patients come down with low pressures, where we use IABP, probably it's claimed as a cardiogenic shock, though may not be directly as a shock situation, but bradycardias leading to hypertension, all that could be clubbed as cardiogenic shock. It's IABP usage is done in about 632 patients. Some of them were used for the cardiogenic shock and some for during procedures. Coming to the thing which many industry colleagues and some of you are interested to note is the data regarding the stents. Total stents which were used according to our information which we got is about 5,11,389, out of which predominantly about 97% are drug-eluting stents, obviously. Then if you see the trends in data usage of compared to total stents versus deaths, it's almost narrowing down. In future, I think we may have only deaths coming up. I'd like to mention here that stents are the things which change interventional cardiology. We never have now CABG standby, but stent by. One single contribution which has changed interventional cardiology, if you ask, probably everybody will agree that is the stents which have revolutionized interventional cardiology, and we became more confident to deliver goods to patients by stents. So there is no doubt that stents is the best which could happen to patients as well as interventional cardiology. But what is of late bothering is, after Bollywood, stents has become the favorite gossip word for every patient, every other person in the country, unfortunately for right or wrong reasons. So some of us who are involved in it, I think we should try to clear out all the misleading, deceptive doubts about this, and then probably have a common forum by which we should interact with press, and probably CSI could ask NIC chair or somebody to interact with the press, basically to remove doubts on this important modality of therapy to these patients. Coming to number of stents which individual doctors have reported, what we got, as I mentioned, out of the right-out column is this, which number of procedures, but we have collected with right information regarding this number which is reported by doctors, our fraternity. Though industry feels this is less, but that's what we have. And I thought first it's my sincere duty to express what we collected. So out of this, multinationals versus Indian stents, I think there is fair amount of competition going on. About 57% are multinational stents and 43% being Indian stents which are being used in the country. And the leading player in multinationals is Abbott, which about 1/3 share market. And the Indian companies, all the three, have fairly going neck to neck, about 10% plus margins to each. And the miscellaneous, what I've included is anybody who has less than 1% share, I clubbed them to miscellaneous because that I thought is reasonable. And that's how this is what is the data which we collected. And because this is not 100% data collection, it's about 70–80% reflection of numbers, then probably I thought I would check from industry as well as for governmental information. So this is the data which industry gave and which we collected from government. And probably, roughly, if you see, almost everything goes together, but for some few minor variations which would happen because in the process of reporting or in the process of importing. Another very good thing which happened in our country is Indian companies are making us proud. Like in pharma, even in the stents, Merrill, Sahajan, Translumina, we have yesterday's symposium also happening, making us proud. Apart from the Indian sales, they also have a lot of exports. I was surprised to see the Merrill is exporting more than what is selling in our country. And same, some numbers are there with Sahajan and Translumina. Many other companies maybe have missed out here because we don't have the information here, but these companies are making us proud, and only wish is basically that probably proper research should be conducted, multi-center trials should be done, and then probably we could have more Indianized data, which is our Indian stents. One word which I specifically wanted to mention to the leading players, especially multinationals, company players here, is whoever is having maximum number of business. It is also imperative on our part to help our poorer subpopulation of the patients. The major chunk who has a business, who says, I don't want to get into the poorer insurance society, that is doing disservice to patients, I feel. It is imperative for the bigger partner, bigger player, to come and help our needy patients. So I make an earnest request to all the people who are not into the poor patients insurance to come into it and help our patients. Other thing which I wanted to make it clear upfront is society meeting, CSI NIC meeting, is our society meeting, and all the companies who have reasonable amount of sales should participate. It's not right to put various conditions. Dr. Sridhar was facing some troubles. Some of them helped in a big way. Obviously, such meetings cannot happen without your help. But whoever is not participated, I again say, request them to take it seriously and try to help in organizing such good meetings. And obviously, Indian companies are helping, and we wish everybody will participate in such academic endeavors. Then, before we shift out from coronary interventions, it's heartening to note that deaths are less common. About 1.1% are reported. In the primary PCI, though it had little more deaths, obviously because of patients come very late, sick, the 2.78% is the 1480 deaths are reported in primary PCI. In hospital events, emergency CABG is less than 0.5%, but still it is there. Then QMIs are reported are 2,712. Renal failure and major bleeding as depicted. Now I move on to peripheral interventions. Renal interventions we thought would come down significantly, but we are 2,049 procedures are reported. And carotid interventions are 1,765. I mentioned one of the leading centers, which is from Andhra. Peripheral interventions are about the same, 10,000 plus. And that's valve interventions. As we are thinking, India is rising. And percutaneous balloon mitral valvolectomy is about 8,860 patients, significant numbers coming from Jayadeva. Then total number of towers, this is again a new interesting thing which is coming up in our total number procedure in, maybe some more are done of late, but this is 2017 data, total number were done, what we collected, reported is 140, out of which predominantly our core valve, Edwards is just coming up. I'm also proud of Medal, which is coming up with my valve. About 30 patients are being done and doing a multi-center trial, which was one was demonstrated yesterday, one will demonstrate tomorrow from Citizens. And then structural heart interventions. It's also important for all the adult cardiologists to understand this, that not only pediatric colleagues, a lot of adult procedures are done in equal numbers. Be it PDA, ASD device, VSDs, and some post-MI VSDs are also depicted. About 10,000 procedures are done by adult structural heart disease patients. Doctors. Neonatal interventions, I'm not going to detail too much for sake of time, but various things are mentioned here. Ductal stenting is again come up as a newer modality which has replaced shunt surgeries in pediatric population. Device therapies, again, this is a pediatric subgroup. Similar numbers like in adult are reported by pediatric intervention data. About 3,000 plus ASDs and 713 VSDs, and PDAs again huge number, probably is more common with various types of insurance schemes, low-cost schemes coming up. A lot of these patients could get therapy early now. Then balloon therapies are mentioned here even in childhood, even less than 12 years, about 1160 PBMVs are reported. And obstructed TAPC, there may be some things wrong mentioned there. EP procedures, single chamber, dual chamber, lot of procedures come up from Kolkata towards this side. And as the numbers, 11,000 plus dual chambers and about 13,000 single chamber pacemakers were done. About 30 CRTD devices, one-third of 1,000 of CRTD devices were done. And some of these newer procedures are on the horizon. Before I conclude, I'd like to briefly mention that LA appendage occluder device implantations, 65 are reported in our country. And rising percutaneous towers, especially newer indigenous valve systems coming up, which could be more cheaper, which could be again become useful or surgical alternative to surgical AVR. And percutaneous mitral valve repair replacement procedures again started doing, and at same Edward devices are being implanted for degenerative bioprosthetic valves conditions. And paravalvular leaks is another condition which is being done. About 24 are reported. Another important area which younger colleagues could take up, I feel, is acute stroke intervention. Not many neurologists are interested. Not many interventional radiologists are there. In our hospital, we started a stroke unit programs. There, we need more of interest coming up, and it will work. If you have a better clot retrieving devices and patients coming on time, now data is there that about 12 years it will work, and probably more of you people should be interested because there is a requirement for patients. Coming to, before I conclude, what are the challenges and some of the suggestions from our end is we have a reasonably good established system. Those people who have contributed last year, they tend to contribute again and again. But what we should have is a simple online data entry formats, I feel, both electronic, web-based, and maybe we can continue this traditional system also. So if the patient procedure is done and immediately it is entered, the day-to-day, the reporting errors could be less. And at the same time, we should devise a system where that format should be also useful in day-to-day practice to report the procedure. That's where I think all of us will use it. So in the coming 1 year, if possible, I would like to wish to launch a web-based data entry with the permission of CSI and all others, and probably app-based programs which are now become available, where you scan the barcodes of the stents and the devices which you used, it should automatically get stored so that authenticity is better, and then probably we should work positively more on that angle. So what we have is a present way of data collection, is collection of data manually, organizing data, me and Sudhir, somebody else sitting, analyzing for hours together, the Excel sheets, and then we come into conclusion. What we should have is immediately after the procedure is done, probably if the data is collected, transferred online, analysis goes on every time, that's where it could be the best way to put forward. Some of the newer research initiatives which could happen if you have a proper data collection is a lot of multi-center registries, trials could happen, and a grouping of hospital chains and like-minded dedicated centers would probably come out with more interesting data, like how it happens west. And then wish to create separate registries for lesion subsets and clinical scenarios. Dr. Pratap, a good friend of mine who's sitting here, who wants to continue with CHIP registry, like that STEMI registry, NSTEMI, TAVR, CTO bifurcation registries, which would maintain where the data is immediately entered so that we could have more positive research outcomes coming from it. Some of the research initiatives which took suggestions from the seniors of CSI NIC is we would like to introduce what is called as micro fellowships. I have identified some centers which do high volume work. I requested them to allow the fellows or junior cardiologists coming from other centers for 1 month micro fellowships. This is being practiced in Europe. We could have one. And some of these centers, doctors coming from Indonesia, other things also are coming up. And we wish to establish some hands-on training centers like in Japan. Through our earlier foundation, we already established one. We don't mind offering the same to all the colleagues across the country for DNB trainings. And the virtual cath lab we are working on, and then animal hands-on sessions. And anything like that, if it comes positive research outcomes, please suggest us, write to us on csinic.com, and we'll try to implement. So let us do positively something, make CSI NIC more stronger and useful to all of us. I feel all the governmental decisions pertaining to interventional cardiology, all the outcomes which happen to the patient should go through our body so as to improve it. To conclude, the gist of all the presentation which I made, we have collected about data from 705 centers, showing a total number of PCIs with 3,86,000, stents being used about 5,11,000 plus. 3.3%, about 20 centers are doing more than 2,000 PCIs. Leading center is Jayadeva. Younger patients are about 12%, but improving numbers are also noted in elderly patients. Primary PCIs contribute about 50,000 plus. Insurance, low-cost insurance schemes, now it could increase further with Modi scheme coming up, is about 43%. Private insurance is about 17%. Self-financing is 40%. Predominantly single-vessel disease. Doubled number of left main interventions are noted, and significant number of, it is 14,000 there, CTOs, and the good outcomes are noted with less than 1% mortality reported. What we need to have is improved data accuracy. All of us should take it more seriously and improve and send our data like how Jayadeva does it. I wish them, again, congratulate this unit, and more positive research outcomes could come. I think with this, I would and a lot of criticism keeps happening from our country. Good and bad is there everywhere, and same is in India. Whatever you have, whatever systems we come, if you have to live here, you have to follow the rules of the land. And I feel this is the only country where such therapy is offered at such a cheaper price to the needy patients. That's how I consider be fortunate to be in the part of this country. So Mera Bharat Mahan, and that's how we have to all plead to do good to patients, and thankful to all of us, of our patients, for giving us an opportunity to serve them. Thank you very much for patient hearing.
Thank you, Dr. Srinivas, for a lovely presentation. Can I request you to take the seat? And